Cool. Hi, everyone. I'm Connie, Yan Tse. Thank you for being here so late at nearly 6, so thank you for joining. I have no disclosures. As we all know, many factors contribute to TMS outcomes. However, functional connectivity and clinical factors have received the most research attention to date. In terms of connectivity, the knowledge that the connectivity between the DLPFC and the SGACC connectivity may mediate TMS outcomes have driven substantial advances in TMS targeting, leading to the development of connectivity-guided TMS tailored to the individual connectivity profile between the DLPFC and SGACC, with improved treatment efficacy in treatment-resistant depression. On the clinical side, data from large-scale naturalistic and RCT samples with more than 300 patients have implicated psychiatric comorbidity, previous treatment failures, and concurrent medication status, particularly antipsychotic and anticonvulsant use in less favorable outcomes. So it is clear that both factors contribute to TMS outcomes, but they're seldom investigated together. This is an important knowledge gap given the evidence of functional connectivity variability in association with clinical features that are very relevant to treatment-resistant depression. And more importantly, this variability can mediate antidepressant outcomes. Indeed, there is preliminary evidence that this clinical complexity and connectivity interaction may also apply to TMS outcomes, even in connectivity-guided TMS. In a recently published study conducted here in Australia and Queensland Neurostimulation Centre, QNC, as we can see in the bar plot here, the patients without any psychiatric comorbidity, group 1, has a much higher response rate compared to those with at least one psychiatric comorbidity, group 2, and those with bipolar depression, group 3. So this raises an important question. How do we improve TMS treatment for those with complex presentations who tend not to respond as well to TMS? This requires a better understanding of how the TMS, or how functional connectivity interacts with clinical factors to shape TMS outcomes. To this end, we evaluated the performance of predictive models based on functional connectivity alone, clinical factors alone, as well as their combination. In a combined cohort of 96 adult patients with treatment-resistant depression from Brisbane, QNC, and Melbourne, involving connectivity-guided and conventional skull-based TMS, respectively. So to capture a continuum of clinical complexity, we derived a clinical complexity weight index summing the presence of bipolar, schizophrenia, or schizoaffective diagnosis, the presence of neurotic or stress-related diagnosis, namely anxiety, OCD, or PTSD, the presence of other psychiatric comorbidities, total illness duration, total number of previously failed treatment across ECT, TMS, and antidepressant, as well as their concurrent medication status during TMS treatment. So these categories are either binarized or normalized with a maximum score of 1 to avoid disproportionate influence from any single category. So every subject will have a maximum score of 6. And overall, this clinical complexity index captures the broad influence of psychiatric comorbidity, treatment refractoriness, and medication effect in accordance with past large-scale clinical studies that I mentioned before. In terms of the connectivity-based prediction model, we adopted the RMAP approach. This whole brain map captures the correlation between functional connectivity and outcome as measured by MADRS percentage reduction for every connection between the DLPFC stimulation site and the whole brain, with age, sex, and site included as covariates. To further ensure generalizability, we adopted linear cross-validation, generating the RMAP in the N-1 training sample, and then correlating this RMAP with the DLPFC stimulation site connectivity map of the left-out individual. This gives us a similarity to RMAP value for every patient. And this allows us to use these values to correlate with the actual outcome to see if higher similarity to the group average RMAP does indeed translate into better outcomes. There were no significant differences between sites across age, sex, and illness duration and symptom severity. However, symptom improvement was significantly lower in the Melbourne cohort, as well as the clinical complexity index was significantly higher in the Melbourne cohort that was primarily driven by a higher proportion of patients with comorbid anxiety, PTSD, or OCD comorbidity, as well as a higher number of previous treatment failures. Moving on to the results of the predictive models. So clinical complexity alone can predict outcome as reflected by a significant correlation between the actual and predicted outcomes. However, this did not survive the effects of sites when sites was included as a covariate. But the significant site differences across outcome and clinical complexity might have influenced this correlation to some extent. And similarly, connectivity-based RMAP alone prediction did not survive site effects as well. However, when we combine both clinical complexity and the RMAP, we observed the strongest performance with improved robustness against side effects, albeit at a trend level. So overall, supporting the added value of clinical complexity to connectivity-based prediction. Now that we know clinical complexity information is important, next we asked which of these factors contributes to the more superior outcome prediction by combining the RMAP with each individual factor in prediction of outcomes. And this revealed that total treatment failures as well as illness duration were the only significant factors overall pointing towards treatment refractoriness as the key clinical determinant. Next, we wanted to see if clinical complexity also influences connectivity markers of outcomes. So we identify brain regions significantly associated with the interaction between symptom improvement and clinical complexity while controlling for symptom improvement, clinical complexity, and site as covariates. This reveals the SGACC, medial PFC, and the chordates as significant brain regions. To delineate these interaction effects further, we extracted the mean connectivity of this significant cluster and stratified the group into high and low complexity subgroups. This revealed that a more negative connectivity between the DLPFC and this significant cluster was associated with greater symptom improvement that was specific to the high complexity subgroup denoted in purple compared to low complexity subgroup where a more scattered distribution was observed. So overall, we found that predictive model combining clinical complexity and functional connectivity yielded the strongest performance and with the highest robustness against site-related confounds. And treatment refractoriness as indexed by illness duration and total treatment failures was the key clinical determinant. We also identified a connectivity marker of TMS response specific to high complexity. So this perhaps means that there may be potential to expand the canonical DLPFC, SGACC, TMS target circuits to also include the medial PFC and the core days for more complex presentations. And lastly, I wanted to note that in order to maximize the sample size and harness sample TMS and neuroimaging protocol variability to ensure generalizability, we combined two independent clinical cohorts. However, the significant site differences across outcome and complexity may mean that we have also inadvertently removed some variants of interest. And perhaps the differences between connectivity-guided and scope-based targeting reflects an aspect of clinical complexity that should be incorporated into the index rather than as a covariate. So to address this issue, further expansion of the sample, particularly validation in a third large single-site data set would remove the need to include sites as a covariate and could help verify our findings. Lastly, I would like to thank my supervisors, Robin, Andrew, and Ashwin for their support throughout my PhD. I've truly learned a lot from every one of you. And I would also like to thank my collaborators in Melbourne and Queensland, especially Queensland Neurostimulation Centre, for generously sharing their data that allowed this project to happen. And I also have a poster session tomorrow at number 75. You can also reach me on these channels. So thank you for your attention.
Okay. Thank you very much for your wonderful talk. There's a quick question that seems your Melbourne dataset and the Brisbane dataset in the treatment response, they have systematic difference. Do you have any explanation or speculation?
Yeah, so I would say this discrepancy in treatment efficacy is expected given the increasing evidence of the better response rate associated with connectivity-guided TMS, which was used for the Brisbane cohort, whereas the Melbourne cohort used conventional F3 beam scope-based targeting that might contribute.
Okay, that's because of the targeting.
Yeah, method was different.
Another question from the audience is, what approach would you recommend for incorporating FC changes, for example, Cohen's D, into effect size estimates for study planning?
For treatment planning?
I guess just for sample size estimation, I guess. You use Cohen's D, right? Or use what kind of, what way will you use to estimate your sample size for treatment response?
Okay, so I guess if this is a question in relation to power calculation, that has not been done in my analyses. And I guess the more patients, the better. And that also goes back to my last point in terms of future directions, validation in a single-size, large-scale data set.
Okay, thank you very much.